Welcome to yet another episode of Fellows Corner from Yashoda Hospitals and our IP Institute, and also from Academy of Bronchoscopy. This is a platform where our fellows discuss cases of intervention pulmonary and those cases which we performed last week or in the previous month, and also some cases which we are posting in the coming days, and we need some opinion from experts. So they will be discussing cases this month. We have Dr. Kirtanan, Dr. Mukul, Dr. Hira, Dr. Sahi Vikas. They'll be presenting some interesting cases. And today, our expert is Dr. Tariq Damat from USA, from Houston Methodist Hospital. And he's an expert rigid bronchoscopist. And we have some interesting cases of relapsing polychondritis and also a case of mucopolysaccharidosis with airway involvement. So in my recent interaction with him, we shared some very common interest. And then I thank Dr. Tariq for accepting this invitation at the last minute and give his opinion on the cases that our fellows will be presenting. A very casual platform to discuss cases, and maybe because intervention pulmonary, we have different ways of treating patients. One expert differs from the other. So I think today we have some interesting sessions and we will start the program. Dr. Hira will be presenting the first case, and Dr. Tariq can interact with the fellows and then give us some ideas on what can be done better in these cases.
Yeah, thank you very much. This is an excellent form, and I'm glad. It's my pleasure to be here. So thank you so much.
So I hand over to Hira now.
Good evening, everyone. Today I'll be discussing a case on mucopolysaccharidosis. This is a 13-year-old boy who came to us with central airway obstruction. So he was basically diagnosed at 18 months of age with mucopolysaccharidosis type 6, and he has had a PDA device closure at 7 months of age and recurrent pneumonia history with upper airway obstruction. He was operated, adenoidectomy was done, bilateral tonsillectomy was done, and he has been on a tracheostomy tube since 2022. This is the boy. First, we had when he came to us, we had taken an X-ray. X-ray, the lung fields looked okay to us, and then we moved on to a CT thorax, in which we found that the oral cavity was narrowed with microglossia. There was severe narrowing of the upper airway. There was also a thoracic cavity, the volume was less, and there was also a pectus carinatum that was found. And we could also find that even the lower respiratory tract, there was thickening around the airway wall. So this is the CT picture. You can see on the left side, right, on the distal end of the tracheostomy tube, there is something obstructing the tube. And even on the right side, you can see the airway is not as how we usually see on a CT. And also the lung volume has also decreased on the left side more than the right side. On the right side more than the left side. So we did a diagnostic bronchoscopy, which showed granulation tissue at the distal end of the tracheostomy tube. And beyond that, there was narrowing, which there was mass-like lesion, basically, which was occluding 80% of the lumen. The right main bronchus also appeared very narrow, and there was also supraglottic mucosa looked edematous on diagnostic bronch. This is just a brief video of how it looked. We can see that when we are going down right next to the distal end of the tracheostomy tube, there is something that is actually moving along with phonation, with breathing. And as we advance the scope, we can see that the airway is very irregular and very tortuous. This is what we found when we approached when we were looking for the upper respiratory tract. There was a lot of mucosa looked very edematous. The supraglottic mucosa looked very edematous. Soft tissue edema was there. And it was very difficult to actually navigate the bronchoscope through that edema. It's basically soft tissue swelling.
It was quite a challenging bronchoscopy because the boy could not lie down, and then we have to do it from the front, talking to him. We cannot give any sedation or anything like that because of his airway collapse.
So now we can see we have managed to find the tract tube. So next we did because everything was looking mass-like, we did a biopsy, which came as squamous metaplasia with hyperplasia and negative for dysplasia. The next plan was to actually make the lumen bigger. We went for electroablation.
How far from the carina, the granulation tissue, the distal granulation tissue, how far from the carina, roughly?
So it was almost near to the carina.
Near to the carina, got it. Yeah, thank you.
Maybe I can add something like it was like near the carina, the lateral walls were very narrow. We have soft tissue like projection coming from the posterior wall, which was like 3 centimeters above the carina. The one that's floppy looked like it's more of a tracheostomy related granulation at the distal tip, which was coming in between when it was breathing.
So this is how the airway looked after we did a electroablation of the tissues.
So here you can see when we pull the tracheostomy out, we were able to cut down that floppy tissue. Just trying to create some space because none of the anesthetists were ready to give him some anesthesia to do the procedure, considering his morphology.
So
yeah, this is very good. I'm sorry to interrupt. This is very good result initially. That was under conscious sedation?
Yes, it was like a local anesthesia.
Local anesthesia, yeah.
Local anesthesia without any conscious sedation.
Fantastic, thank you.
So the points to discuss here are like what further we can do, because now this boy after a year he comes to us, and now he has got maggots at the his presentation is like he's got a little bleed from the tracheostomy tube, and when we closely saw he had some maggot infection which we are treating now. We have not got inside. So maybe any experience of yours or Dr. Hira will show some of the literature from the papers, but what best we can do, like in case placing a silicone. The distal airways look okay, the right RMV and LMV.
So this is what the literature says. So mucopolysaccharidosis is a lysosomal disease. It's a heterogeneous group of events happening in the body, basically because the glycosaminoglycans in the body is not degraded by the enzymes which must be degrading the compound. But now we have different types of mucopolysaccharidosis based on the enzymes which is deficient in the body. And usually all MPS are autosomal recessive disorders, but MPS 2 is X-linked. It's basically categorized into 4. When there's only soft tissue and skeletal disease with or without a brain disease, it's MPS 1, 2, and 7. In MPS 6, we have soft tissue skeletal disease without a brain disease. So fortunately for us, our patient is MPS 6. So his everything, he can speak okay, he can understand. So there's no deficit like that. In MPS 4A and B, there is only skeletal disorders without a brain disease. And when there is CNS involvement, it is MPS 3A to D.
But do we have any type where airway involvement is seen more commonly in these patients?
Airway involvement is usually seen in 1, 2, 3, 4, 6, and 7. But there's a slight difference in the airway involvement. In 1 and 2, we have protruding teeth, large tongue, high larynx. In 2, 4, 6, and 7, we actually see tracheobronchiomalacia with tortuous trachea. And basically everything from starting from the upper airway till the lower airways, there's supposed to be glucosaminoglycan deficits that's actually causing the disease activity. And with time, the deposition is going to be more, so the disease is going to progress with time anyway.
Another point here is like we have taken biopsies from all the areas, like including the carina, the primary carina and the secondary carinas on both sides. But nowhere in the histopathology, they mentioned that there is mucopolysaccharidosis involvement. I don't know how, because this is our first case we came across such a disease. So maybe the pathologists are also seeing for the first time in our hospital. So how to decide whether this ingrowth or the narrowing is mainly due to the disease process itself or because of the morphology?
So here are some illustrations I've picked. So this is a high anterior larynx that you see in MPS 1. So when you go to MPS 2, the supraglottis is bulky. In 4, there's also a high larynx with a overhanging epiglottis, as you can see. And this is a large epiglottis, which is actually touching the soft palate, which is Mucopolysaccharidosis 6. Unfortunately for our boy, this could be the way it's presenting. And this is an MRI scan showing again high tongue and large tongue and high larynx and anterior larynx. And you can also see that there is a absence of cervical lordosis. So that makes the airway very small and ventilation becomes very difficult. In this CT scan also, MPS 2, it shows a large bulky tongue, a flat palate, again with a short neck, which is very prominent, and again absence of cervical lordosis. This is also MPS 4, again showing there's contracted nasopharynx, making breathing difficult. This is a CT scan showing a collapsed trachea, suggestive of tracheomalacia in a MPS 2. So I have a few pictures of the three-dimensional reconstruction of trachea. In MPS 1, not much of tracheal involvement, so it looks normal. In MPS 2, there's, like I mentioned before, there is tracheomalacia. This figure shows that. And MPS 4 also, there's tortuous trachea and tracheomalacia. This is our child, MPS 6. You can actually see that the trachea looks very tortuous, making ventilation very difficult. Same with MPS 7. So there's also a way to assess the airway complexity. It's called Salford MPS airway scoring system. It has 15 parameters, out of which the first 10 reflects the upper airway, 11 to 13 will reflect the mid airway, and 14 and 15 will reflect the lower airways. So the first one is mouth opening, teeth protrusion, cervical spine mobility and stability, tongue bulkiness, modified Mullen-Beatty grading, and thyromental distance. This can be actually assessed with a clinical examination. Now, from 7 onwards, larynx height, epiglottis bulkiness, supraglottis bulkiness, and glottis bulkiness can be actually assessed by a nasal endoscopy. And again, there's also subglottis diameter at cricoid level, tracheomalacia, tracheostenosis, and tracheal tortuosity. And again, FEV1 and FVC, which can be assessed by a pulmonary function testing. So after you get a scoring, it's out of 45. The bigger the score, the more complex the airway is going to be. So coming to the management of the patient, usually less severe cases can be conservatively managed. We can give a CPAP for any sleep-related problems, physiotherapy for secretions. These children will have a lot of thick secretions, which is very difficult to remove. So physiotherapy would help. And sometimes in case of MPS type 1, 2, and 6, enzyme replacement therapy is supposed to help to some extent. And when nothing helps, the only way is to surgically intervene. Like our case, the first line of management was surgical management was an adenotonsillectomy, which was done. And later he was put on a tracheostomy tube. So now at this point, when he has come to us, we had to do an ablation. We have not done a laser ablation, but we have done an electroablation. Other modalities of treatment could be if there is multi-level stenosis, then we might have to put the patient on a T-tube. And tracheal stents can also be placed depending on the severity. And I had also tried reading what kind of stents we usually prefer. That again depends on the stage of the disease, how much it has progressed, how much longevity, how bad is the situation. We'll have to assess accordingly and try a stent placement. This is just a picture of the T-tube we can place. These are a few stents. And now the problems encountered while after we put any kind of airway in these children or this is that the disease is very progressive. So even if we put something, we might have to keep changing or changing according to the disease progression. And because of granuloma formation and deposition, because of the mechanical irritation, the more mechanical irritation, the granuloma formation is going to be more. That is going to be one more challenge we'll face when putting a stent. And because there is going to be several types of airway stenosis involved, like malacia, mucosal thickening, external compression. Sometimes these glucosaminoglycans will deposit in the mediastinum, actually compressing the airway so much so that with disease progression, it is going to be the way we'll have to intervene will be very difficult. And so overall, the management for airway involvement in MPS is a very complex thing to do, and the success rate is pretty, it's only moderate, and we will need a comprehensive and multimodal approach for approaching these patients. Thank you.
This is definitely a very nice case, very complex and very challenging. Congratulations for taking care of this patient. This is very interesting for sure.
Any comments on placing some silicone stents? Because this guy, we cannot do anything from above. Whatever we place, there might be a time when you have to remove, which might be difficult with his stature and through the tracheostomy, because it's very difficult to put a rigid bronchoscopy through this guy's tract tube.
So you're saying it is difficult to put the small rigid through the stone?
His face is very bulky, and then you get that space to put the rigid bronchoscopy.
Yeah, this is really challenging. I mean, I like the idea what you did with electrocautery or laser or so. Yeah, I think maybe this is a case where it needs a lot of patience and repetitive interventions. But then probably Montgomery tube is the way to go, I'm assuming. But still, Montgomery tube is, but as you all know, better placed with rigid bronchoscope rather than blind in case you lose the airway. Can you go with rigid scope through the mouth, or is it very difficult? Impossible, yeah. Yeah, very difficult. So, I mean, silicone stents usually placed with rigid scopes, challenging, and I'm not sure. Maybe just tracheostomy is the way to go, and change the tracheostomy often, and just cut the granulation tissue and see how it goes. But this is very challenging. So
that's what we plan to do, like repeated ablation using whatever things we have, and then we keep repeating. Thank you. And we go on to the next case presentation.
Perfect.
Who is presenting? The next case will be by Dr. Kirtanan. He will be presenting a case of relapsing polychondritis with airway involvement.
Hello, I'll be presenting a case of a 40-year-old female who's a known case of relapsing polychondritis, who was on and off treatment since 2011. Status post hybrid airway stenting, which occurred on September 2024. She presented to our center with the noisy breathing since 3 months and cough since 3 months, and she's reporting that she is expectorating small stent fragments while coughing out. Coming to the chain of events of the patient's history, she initially presented to her local hospital at around in 2007 with complaints of swollen right ear, right knee pain, and shortness of breath. She was diagnosed with laryngeal and subglottic stenosis and underwent stenosis resection followed by tracheostomy plus stenting. She doesn't give any history of being evaluated for the cause of stenosis, but and there were no documents available with her for the same, and the stent was removed 12 weeks later. During the course of 2007 to 2010, she recurrently visited the local healthcare center with complaints of right ear pain, costochondritis, right knee pain, and she took symptomatic treatment. In 2010, when her shortness of breath had reduced, a decannulation was attempted, but it failed and she was re-tracheostomized. In 2011, she had visited another center where she was diagnosed with relapsing polychondritis and started on dapsone and prednisolone. She stopped dapsone due to adverse events like nasal epistaxis. From 2011 to 2024, patient reports taking methotrexate and prednisolone on and off due to patient preference and non-compliance to treatment. There's also some history of trying herbal remedies. In September 2024, due to worsening of breathlessness, she underwent hybrid stenting and has been on methotrexate and prednisone since 1 year.
So to summarize the events, like this is a female who is an African national. In 2007, the initial presentation was like subglottic stenosis and laryngeal stenosis. So they did not diagnose relapsing polychondritis at the time of this stenosis evaluation in the beginning. And later, she had some resection surgery, which the reports we don't have exactly how the resection was done. And following which they also put the patient on some tracheal stent. Again, we don't have the reports of those things, which they mentioned as they removed it after 12 weeks. And recent history of again one medical therapy. Later, she was diagnosed in South Africa to have relapsing polychondritis, for which she was on medical management. She was doing well until 24 when she had this one episode of worsening shortness of breath. It looks like it was an emergency where they had to put some, though they mentioned it as a hybrid stent, what we can see through the bronchoscopy is like they just put one metal stent through the tracheostomy tube. So this was the history of this patient in brief.
Here we are presenting the coronal section, which was done at an outside center around a month back. Here we can see the tracheostomy tube in situ in the coronal section and the placement of a metallic stent just below the tracheostomy tube. We can see that the metallic stent is ending above the level of the carina. We had repeated a CT scan of the airways at our center. Here we can see that the stent is in situ, but it seems to have slipped off a bit and is extending into the right main bronchus. We see a subglottic stenosis and the distal tip of the stent is extending into the right main bronchus. A check bronchoscopy was done using a 4 mm scope. We can see that the vocal cords are edematous. And there's the tracheostomy tube in situ. Bronchoscope was passed through the tracheostomy tube to visualize the airways. We can see that there is extensive granulation above the stent, and there is granulation tissue at the distal end of the stent as well. The stent seems to be resting on the carina. There seems to be malacia component in the right main bronchus and severe narrowing as well. Scope was then negotiated into the left main bronchus.
Now the patient has a stent which is causing a little obstruction. So displaced stent with a little granulation, and through the tracheostomy, this is the picture. So what I request Dr. Tariq to give his comments on like the patient was referred here from Ghana for a stent removal. She has a stridor at rest.
Yes. So a couple things. The first thing is, as you see, to the fellow colleagues, the stent is close to the carina, right? And so when the stent is close to the carina, there is the rule of 2 centimeters. So when the stent is placed close to the carina, less than 2 centimeters, the carina, this problem can happen with granulation tissue that is obstructing the airway distally, and so on. So it's important to put a stent that is 2 centimeters away from the carina, or you have to put a Y stent if the stenosis is very close to the carina, less than 2 centimeters. And the same thing applies to the vocal cord, whether you put a Montgomery tube or you put a tracheal stent. So you have to have some margin of safety. That's one. The second thing is I would suggest that this stent be removed. And removal of the stent can be done through a rigid bronchoscope, whether you go through the stoma or whether you go through the mouth. Taking the stent out is interesting because you do not want to perforate the airway or remove a lot of tissue if it is stuck to the trachea and have an injury to the trachea. So the best way to do it, in my opinion, we go with the rigid bronchoscope through the stoma or through the mouth. Maybe through the stoma will be easier here. You take the tracheostomy, you still ventilate, and then of course, a patient is sedated, and you try to put the rigid scope, try to basically just hit the stent and just take it with the bevel, and then like as if you are scraping it off the airway, and rotate and rotate and rotate and rotate, so until it basically comes off the airway safely. We have to be very careful. When you do so, hopefully the stent will come off, and when it comes off, you remove it and you intubate with the rigid scope right away, and you ventilate to the level of the carina. And then after that, I would place a Y stent. After you measure everything, make sure everything is fine. Silicone Y stent probably will be a good stent for this particular airway. So that will address this upper airway. And then after that, probably we place the tracheostomy to sit in the tracheal lumen of the Y stent, if we think so. Or you can leave it the same way and away from the lumen of the Y stent, the tracheal part, and see if this is sufficient. I think these are, you're presenting very difficult cases. This is actually the difficult cases in interventional pulmonology, period. So congratulations for taking on such very complex cases. But I think this is very important to be careful. Rigid bronchoscope is probably the method of choice, in my opinion, and silicone Y stent rather than metallic or anything that has metal in it, because it will probably be more appropriate for a benign disease like this. And at the same time, you're optimizing her medical therapy with whether methotrexate or rituximab. For severe cases, you can use rituximab, or sorry, not rituximab, infliximab actually, and see if patient can tolerate better, and every maybe 6 months remove and see what's happening. and so on. And keep in mind, Y stent will actually accumulate a lot of mucus and so on. So you're going to bring the patient back and forth and clean the airway and maintain it somehow. But this is probably how I would do this case moving forward. But I'm open to suggestions. And Dr. Harry, if you have any other suggestions, please go ahead.
Yeah, thanks for your inputs. My plan, I was thinking, I go because this patient has space, can go through the cords, and then take the stent out so that I can visualize the whole trachea once, rather than going to the tracheostomy, because our experience more removal of stent through the upper airway. And we usually, what we do when we do metal stent removals is we take the large number of Fogarty balloons, place them on the corners into the stents in all the corners, and then try to inflate in a different angle so that the stent gets dislodged from the mucosa and then it gets free. And then after that, we try to remove the stent. This is one approach what we follow in our hospital. My main thought process in this case is like whether we should, once we remove the airway, like the stent, if the patient has, because since it's a metal, maybe there is some remodeling that happened in that area. So I was thinking if there is no Malaysia, since the left main, if you see closely, it's good airway, like compared to the right one. Right one looks a little more narrow than the left. So I was thinking, should we wait not to place anything in the beginning, wait for 3 days after the stent removal to understand how the patient is doing? And maybe in future, should we plan like a biodegradable stent on the right side and keep the left one a silicone? That is what I was thinking, rather than putting the Y in the beginning, because the limbs of the Y, again, lot of secretion, cleaning, because the patient has to go back to her own country. Again, we need expertise at the place where they should also understand what we have done for this patient. Because if you see the left main, I feel like this is much wide open than the right one.
Yeah, this is actually a great idea as well. And you're right. Probably we wait and see, give it time and see, because you're right. Sometimes the airway has refibrosed, remodeled, and does not require immediate stent. And yeah, and a lot of this granulation tissue and so on, it will be nice to resect it with rigid bronchoscopy for sure. And the rigid bronchoscopy, it does provide, as you know, it basically, provide stability to the airway. It's remake the airway very nice in these cases. But I like your plan very much, because you're right. Patient is from other country, and you don't have immediate access to the patient in case there are problems. Yeah.
Thank you. And we go on to the theoretical part. I think that's already discussed. Maybe we put on biologics like infliximab after we remove the stent and see. That also is in the plan from the medical side. I think we will go on with the discussion quickly.
Okay. Relapsing polychondritis is an immune-mediated disorder with no known exact etiology. It is associated with inflammation in cartilaginous structures and other tissues throughout the body, especially in the ears, nose, eyes, joints, and respiratory tract. So the usual presenting symptoms is auricular chondritis. Early stages of lower airway disease may be asymptomatic, and these patients are usually assumed as refractory asthmatics, and they respond to corticosteroids, which further delays their diagnosis. Symptoms of large airway disease include hoarseness, aphonia, wheezing, inspiratory stridor, non-productive cough, and breathlessness. Relapsing polychondritis usually causes tracheobronchomalacia and tracheal stenosis as the disease progressed. Around 50% of the patients will develop some respiratory pathologies in the course of their life. Although there is no gender predisposition, severe airway inflammation manifestations are more common in females. Treatment modalities is a multidisciplinary approach which involves immunosuppressants and some airway intervention if the patient is severely symptomatic. As we can see in this pathophysiology of the disease, due to some repeated constant trauma or due to some inciting event, the relapsing polychondritis might trigger. acute inflammation and airway edema occurs, which leads to chronic inflammation. And as the disease progresses, they develop fibrous tissue deposition leading to airway stenosis. Coming to the medical treatment, as it's a rare disease with the incidence reported around 0.36 to 3 per million population, the treatment there is no standardized protocol as there's no available RCT trials. Primarily, it has been symptomatic. Initial management may revolve around giving NSAIDs, corticosteroids, and/or immunosuppressants. But these treatment modalities have not found to retard the disease progression. Newer modalities have involved in biologicals and anti-TNF alpha, infliximab, etanercept, adalimumab, anti-IL-6 tocilizumab, anti-CD20 rituximab have shown promise. But all these studies are case reports, so we will have to analyze as case per basis. Anti-TNF alpha, especially infliximab, has shown some 86% positive response in patients with pulmonary involvement manifestations in relapsing polychondritis. They have shown rapid improvement in their symptoms, and their efficacy may last up to 3 years. Coming to the intervention part, if the patient is severely symptomatic, showing subglottic stenosis, airway stenosis with tracheobronchomalacia leading to severe breathlessness, airway stenting may be considered with or without tracheostomy. In a study by Ernst et al. With around 145 patients of relapsing polychondritis, 31 patients had some form of airway involvement, where 70% were female. 13 of them had some form of intervention done, maybe dilatation, stenting, or tracheostomy, and they had observed that there was symptomatic improvement post-procedure. In a study by Zhang et al., 13 cases of exclusive airway involvement of relapsing polychondritis was evaluated, of which 6 underwent stenting procedures, and 5 of them had reported significant improvement post-procedure. The one patient who did not report improvement was put on positive pressure ventilation. Kuo et al. Had 34 patients of relapsing polychondritis, and 4 reported critical airway involvement. 3 eventually underwent tracheostomy with or without stenting procedures. All of them underwent metallic stenting or silicone stenting procedures based on the patient criteria. Sarodia et al. Reported 5 patients having clinical improvement with SEMS placement. All these studies reported that the patient improved post-stenting, but in a recent study published by Handa et al. In 2023, who studied 77 patients of relapsing polychondritis, 13 underwent stenting procedure, but 10 succumbed to the disease. Of the 64 patients who did not have any airway stenosis, 18 underwent tracheostomy due to breathing issues. 13 had no airway stenosis. 18 who didn't undergo stenting underwent tracheostomy, and this limb of patients had lower mortality rates noted. All of these patients were put on some form of biologicals. It may be infliximab or rituximab. So the Rheumatology Association suggests that less severe form of relapsing polychondritis be started on NSAIDs, colchicine, dapsone, with more severe with organ involvement, stepping up the immunosuppressant, and the refractory cases be started on biologicals with surgical intervention as and when needed. At present, there are no treatment guidelines for relapsing polychondritis. Systemic corticosteroids and immunosuppressive agents are standard medications. Early administration of systemic steroids and immunosuppressive agents have found that the patients developed critical symptoms much later in life. Biologicals have been shown to form some disease retardation features, but more clinical trials are needed to prove their efficacy. Stenting in cases of critical airways have shown to be providing clinical relief to the patients. Thank you.
Yeah, very nice case.
I think
Thank you
the
so
time is
much.
clear, Dr. Tariq.
I appreciate that, Dr. Hari. I have to catch a flight to San Francisco. So thank you for having me very much. This is actually fantastic, and congratulations for this fantastic form of discussion these cases.
Thanks, Dr. Tariq. I will take on from here, and then thanks for joining once again.
Thank you again.
You
Thank
in our forums.
Thank you. Bye now. Bye-bye.
So we continue with our next case discussions. We have 2 more cases. One is a patient who had massive hemoptysis following ultrasound guided lung biopsy. And the other patient had a impacted airway foreign body. A bit tough case to manage. So we have Dr. Mukul, who will be presenting the next case on management of a patient with an emergency code blue claw following an ultrasound guide biopsy of a lung nodule. So Dr. Mukul will present the next case.
Evening, everyone. Myself, Dr. Mukul. I am IP fellow in Yashoda Group of Hospitals, Sikandrabad. I'm going to present a case of bleeding as a complication after ultrasound guided biopsy. So here is the case details. 62-year-old male presented to us with complaints of cough, fever on and off since 10 days, associated with loss of weight and loss of appetite. Initial investigation showed a TLC count of 25,780, and the rest of the blood work was normal. All investigation rest were within normal limits. So we did a CT chest which showed a multiple solute nodules bilateral, largest being in the left upper lobe and left lower lobe, around 6 centimeters with cavitation within, and mediastinal lymphadenopathy, largest being subcarinal. So CBC guided biopsy of the nodule was planned. Left lower lobe nodules was targeted. The position of the nodule was located with the signal from radial locus, and then using bone beam CT, the biopsy was done with locating needle in the 3 planes using augmented fluoroscopy.
So though the nodules in this patient were multiple, there were 2 biopsies from the bronchoscopy, and then which turned out to be more of organizing pneumonia in this patient, if I remember well, right? So the initial differentials included metastasis also, considering multiple nodules, randomly distributed nodules. But he had all the biopsies that were done next showed more of neutrophilic inflammation and organizing pattern, if I remember in this patient. So as a part of our comparison between the bronchoscopy guided biopsy and the other modalities like CT guided biopsy, so we had to refer this patient for an ultrasound guided biopsy, because and then once the biopsy was done, Dr. Mukul will tell you what happened for the.
So after referring the patient for ultrasound guided biopsy, patient as patient developed catastrophic hemoptysis, around 100 ml of blood was lost, and patient also developed sudden hypoxia with loss of consciousness. So patient had to be intubated and shifted to intensive care unit for further management. By doing chest X-ray, we ruled out pneumothorax, and urgent bronchoscopy was planned in ICU in view of suspicion of blood clot, as the patient was not maintaining oxygen saturation. So after initial stabilization, we did a bronchoscopy after intubation, and it showed a big clot in the left main bronchus and upper lobe and lower lobe both. So by bronchoscopy guided suctioning, the clot was removed bit by pieces. So here is the clot which was removed through bronchoscope suctioning, and after that the patient improved clinically, and patient was extubated, and patient was started on appropriate antibiotics and is now doing well. So the even repeat ultrasound guided biopsy HP came out to be dense inflammatory infiltrate showing lymphocytes, histiocytes, scattered multinuclear giant cells, favoring again an infectious and inflammatory etiology. So take-home points from this is that complications of ultrasound and CT-guided biopsies includes pneumothorax, which is the most common complication, then bleeding, infection, tumor seeding. Tumor seeding is a very rare complication where the tumor cells are seeded along the tract of the needle, then air embolism and injury to the surrounding tissue. These are very rare complications. Then while CT and USG guided biopsy is a valuable diagnostic tool, it is important to be aware of potential complications and risk factor associated with the procedure. So risk factors being the patients who are of COPD patients with emphysematous lung, even the patients with the lung fibrosis, in patients with high pulmonary artery hypertension, and in patients with very small nodule, or the part to the nodule is very big, the bore of the needle which we use for biopsy is very large, and the patients who are on antiplatelet agents, ideally it's a contraindication for doing that. But just mentioning that it is also a contraindication that if by any chance we ended up doing a procedure in a CT guided biopsy in a patient who is taking antiplatelet, it might lead to bleeding. Careful patient selection, pre-procedural evaluation, skilled execution, and appropriate post-procedural monitoring can minimize the risks and ensure the best possible outcomes. Thank you.
So the whole idea of presenting this case was to show to understand the complications, because when we are doing a bronchoscopic biopsy, we have a backup tools like a balloon and all, but sometimes these are very an immediate call you get when you're doing some work, and then the radiologist calls you saying that there is a massive hemoptysis. I think hemoptysis is one major complication rather than pneumothorax in my personal opinion, because it needs immediate attention, maintaining the airway. Luckily, a code blue was announced for this patient, and then we quickly put in a tube, and then he was resuscitated, and you can see the bleeding that can occur inside the airway following the biopsy, transthoracic biopsies. So in a way, bronchoscopic biopsies are a bit safe compared to the other transthoracic biopsies. But the complication rate is very less. So this week we had this patient, so we wanted to present this kind of management for the residents. So sometimes it is important for us to accompany the patients when they have a biopsy schedule, and you can be with them and then manage the complication if at all it happens. And next we have Dr. Vikas. He will be presenting a case of a very complex airway foreign body. The complexity is mainly due to, I would say, because of the age group, and also the way the patient presented. He was a little low on BMI, and he had a bigger granulation tissue above the foreign body, and initial attempts was performed at the peripheral center with no success. And then the removal process was easy, not very difficult, I would say, but for fellows learning how you plan these patients with impacted foreign bodies for more than 3 to 6 months, Dr. Vikas will be discussing with us with his next case.
Good evening, everyone. I'm Dr. Vikas. I'm here to explain about a case of foreign body removal, bronchoscopic foreign body removal. Here are the case details. It's a 7 years old male child who presented with cough since 5 months. And there is also history of accidental foreign body ingestion 5 months ago while he's playing. And he was evaluated with a CT chest, which is showing left upper lobe collapse consolidation with air trapping. And there are also multiple centrilobular nodules noted in the left lower lobe. So here we proceeded with first with the check bronchoscopy, which is a very important step before the removal of foreign body to assess the nature and the type of foreign body, and also to assess the airway before retrieving the foreign body.
What you can see here, you can see the left main bronchus is a bit collapsed. There is approximation of the anterior posterior walls with granulation above the foreign body. And as we pass the scope beyond that granulation, you can see, can you play the video again from the, it's a bit chronic based on the bronchoscopic examination. Also, you can see the chronicity, and there is also a bridge that is formed connecting the anterior posterior walls on the medial side. And as you navigate beyond, you can see there is a probably a plastic cap or something like that, which is blue in color.
We can see a bridge of fibrous tissue in the left main bronchus. So we used an electrocautery knife to cut the fibrous tissue to allow the easy passage of foreign body while removing. So a cut is made with the electrocautery knife. Here we can see some mucoid secretions, and the foreign body is clearly visible. And there is some granulation tissue is also around the foreign body.
So, what would be your tool of choice? Would you try to remove this foreign body with a flexible bronchoscope or a rigid bronchoscope? And if you are using a flexible bronchoscope in such foreign bodies, what type of instruments used to retrieval?
We can use a grasping forceps to remove this type of foreign body.
I would say forceps would be a rat tooth or something like that, which can grip the foreign body. A rigid bronchoscopic removal also is a good option in this case, but for beginners, because of the left main anatomy, you can try with a flexible bronchoscopy and then go with the rigid bronchoscopy if you fail to remove the flexible.
So here you can see granulation tissue around the foreign body, and there are plenty of secretions. And now we are trying to hold the foreign body with a rat tooth forceps. And care must be taken here to visualize the foreign body with a clear vision and to avoid mucosal injuries while retrieving. So here, the foreign body is dislodged into the left main bronchus. Throughout the retrieval of foreign body, the passage should be clear and the vision should be clear.
It's important to maintain vision while we remove these kind of foreign bodies, and then where you hook the rat tooth. I think where the compression is more, it's better you pass the rat tooth arm into that area and then just hook till the junction of the forceps goes in not to hook very proximally. Push the forceps a little deep inside till the junction, the bridge, and then hold it. And since once you're able to, I think again that subglottic space is a little important when you remove foreign bodies. because that is one area where they can just get dislodged, especially when you are having the flexible bronchoscopy approach. And it was a pen cap.
This is the post-procedure X-ray, and the collapsed segment of the left upper lobe.
And if you remember well, I think after the bridge is cut with the electrocautery, we did a rigid bronchoscopic dilatation. Means just a rigid bronchoscopic barrel was passed onto the left main just to maintain the patency, and then removed through a flexible bronchoscopy. So this case highlights the importance of flexible bronchoscopy also in impacted airway foreign bodies, which are chronic. Always for beginners is better try with the flexible approach. Not in the very younger pediatric age groups, but if you have a child like this who has got a decent airway where you can place an adult scope also, I think the whole procedure was done using a adult bronchoscope. You can just use the flexible tools to remove these kind of foreign bodies. With that, we come to the end of discussion for this month's Fellows Corner. We will, if you have any questions, you can post it on the group or on the Facebook. We'll be happy to answer, and we look forward for the next month's webinar for the Fellows Corner. Thank you very much for watching, and if you have any questions, just post it down and then we will be happy to answer. Thank you.